comes out that is a budgetary request or justification, and I had been unaware of this new department or sub-department or maybe reorganization of certain areas under the HHS. And it says that it is a major initiative of the Trump administration, of course, and a co-undertaking of HHS Secretary Kennedy, but few people know about this. I did not know that this had happened. So can you tell us about the AHA, and what you're thinking?
Okay, so let's talk about the Administration for Healthy America, which is something that was the subject of our Substack yesterday, I believe it was. And it's part of a effort that I'm in the middle of right now of identifying legislative priorities associated with the Make America Healthy Again movement in the Trump administration. And as I'm just writing a second essay right now, I'm right in the middle of it, talking about that people, there are certainly the trolls and the nattering nabobs, et cetera, that criticize what's going on, and they will always criticize what's going on as not enough, fast enough, et cetera, as a way to demoralize people and spread discontent and promote lack of trust. So we have these various theories that Trump is this or Trump is that, or he's compromised, or he's in bed with Borla, or it just goes on and on and on. But what people don't recognize is that despite the recent protests, Trump is not a monarch, and the administrative branch, the executive branch, are not the ones that appropriate money, and they're not the ones that make the laws. That's Congress. So just kind of civics 101 for everybody, for those that are genuinely confused about how the federal government works. And so the Trump administration, there are many things they can do with their executive order and through a muscular presidency, which there's no doubt that Donald Trump represents a muscular presidency, as did Ronald Reagan and many others in the past. You could even argue that Joe Biden, certainly Barack Obama was a muscular presidency, not my type of muscle, but there it was. He did a lot of executive actions and, launched a lot of wars without congressional authorization, et cetera. So there's a lot that the executive branch can do, but there are limits. And in particular, when Congress puts laws in place saying that this will be done this way, or you shall not do that, or this branch of the administration shall be brought into existence, and here's the budget for it, the president doesn't have the latitude to just disregard the will of Congress, or then it gets routed immediately over to the judicial branch, and we've seen how that's gone. So the complaints that Bobby and the president are not moving fast enough often don't recognize that they're doing everything they can in those areas that they have that latitude. And then in other areas, they have to wait for Congress. And much of the MAHA agenda that we're all familiar with, that's come out in the form of these two MAHA commission reports and the action plan and the huge amounts of things that have been achieved, like the reorganization at ACIP and CDC and so many other things, those are disputed, as we've seen, by Congress from time to time, but they're right at the edge of what the Trump administration is able to do. We need Congress to act. And so I've, because of various speaking engagements that I have and various particularly conservative groups, including legislatures that I interact with, I've been pushing the Trump administration and particularly HHS to share with me information about what they see as the legislative agenda. And in doing that, in doing discovery around that, I uncovered, is actually Jill that did the diligence, the research. This is Dr. Jill Glasspool Malone, my partner in the Substack, uncovered this document that's actually a couple of months old that was submitted as part of the budget request, which is the one that you're referring to. It's over 300 pages, and it describes a major reorganization plan for consolidation and elimination of a number of HHS agencies and bringing those together under one umbrella, groups that have previously been fractured and fragmented into a bunch of little tiny
silos.
Yeah. And so this is the Administration for Healthy America, or AHA. And we drilled into this congressional authorization document, pulled out the justification, and we left the numbers in the report because it just seemed like it was boring to our readers, and put the thing out as a Substack summary so that everybody knew that this was one of the plans. And by the way, it's a major plan which will require congressional action. There are no congressional bills yet associated with it, and there are no congressional sponsors to enable. So you could think of this right now as aspirational. It just so happened, I put that out yesterday morning, and yesterday evening, I was at a meeting of the MAGA Action Group, which is a lobbying group in D.C., where a number of federal officials within the administration were also attending. And so I got a chance to talk to some folks about this. And what they told me was that actually Jill and I got a little ahead of things in uncovering this report. They were surprised that we were able to find it. And
so this is breaking news.
It truly is. It has not been covered at all. So it's not your fault that you haven't seen it. The corporate media has not identified it and hasn't covered it. And HHS communications has not yet championed or promoted this. So that's why you haven't seen an article in Vanity Fair or the New York Times or the Washington Post or the Atlantic Monthly or whatever, Huffington Post, excoriating this, is because they're not yet aware of it, because HHS is not yet promoting it. And one of the things that's going on, you asked the broader question, what's going on in HHS? We're in the middle of a governmental shutdown. I think we're at day 21 right now. And so, for instance, yesterday I was asked by a reporter that was there to provide an interview with her at the White House. But then, and I said, of course, I would be honored to do so. But that's not going to be possible until the shutdown's over because there's no escorts. I mean that in the sense of the young folks that walk people back and forth from the gate to whatever room it is in the White House, because they're all on furlough right now. So that's the situation, is that this Administration for Healthy America, which proposes arguably the most significant rearrangement of those that want to put a negative spin on it might call it rearranging the deck chairs, but it's a major reorganization of many of the HHS functions and bringing them, in some cases, out of certain agencies and putting them into other agencies. I guarantee that when this gets operationalized and Congress gets its teeth into it, there are going to be howls of protest, because that's the way things are in D.C. There's always winners and losers, and the losers always seem to find some excuse for filing lawsuits and going to the New York Times and complaining. So we can look forward to a season of that.
Fun.
That it just decides to socialize it.
Well, it looks to me as if the Health and Human Services is attempting to refocus um, the mandate toward preventative care and flourishing, as opposed to waiting until the kids got type 2 diabetes for some reason, and escalating rates of course,
So thank you.
obesity.
There it is. The fundamental principle is that the Make America Healthy Again Commission action plan is absolutely focused on transforming American healthcare. And I can tell you, having recently been in Europe and talking about this, the Europeans are really intrigued by what Bobby is trying to do with the president right now in refocusing from illness and sickness care to health promotion. So this is the difference between medical treatment, which is the dominant paradigm in our current system, and health promotion. And where that becomes most obvious, that difference is, just to be rhetorical, when was the last time your doctor talked to you about nutrition? When was the last time that you encountered a doctor that had been trained in nutrition in medical school?
When my husband had his first stroke, and he had several then afterwards, what grieved me to no end is that I eventually had to get all of my healthcare advice and do all of my study, which I launched into months of just watching YouTube videos, which had amazing scientists and doctors and healthcare professionals doing, great presentations at conferences and documentaries, because I would go to a doctor. My mother got cancer at the same time. And I would say to the doctor, after they'd given this whole spiel, I say, well, what about carbohydrates and sugar and, metabolic health? Like what? And they'd look at me like, yeah, you should eat better, eat fruits and vegetables. I don't know what. It was just so silly. And it was really a setup question. I didn't attack them, but I thought, is anybody going to give me anything besides, come back in 6 months and we'll take your blood pressure and ask you if you're taking your medications or whatever? It just seemed like that there was no innovation, no curiosity beyond the taking medicines or going into surgery or doing. And that really distressed me. It really distressed me, opened my eyes.
It's the consequences of how the incentives have been structured.
How so?
So all these docs get paid by doing activities which can be coded. There's a coding system. The American Medical Association actually owns it. And here's a fun fact. They generate about $500 million in revenue per year in licensing fees for letting doctors and insurance companies and others use their coding. And if you go to the doc, if the doc wants to get paid, they need to in you into one of those CPT codes and say that Elizabeth has CPT code XYZ, and therefore I did procedure ABD, which is aligned with that CPT code. And so now I can charge for that procedure code. So she needs to have a diagnostic code and then a medication or procedure code. And then I can bill that and get insurance reimbursement or from Medicare, Medicaid. And so the whole system is driven now by whether or not you represent a BIN code. It can be applied to you that a doc can use to get money out of the insurance companies of the federal government. And remember, 80% of the docs are now, you might say employees, I might say indentured servants, but we get the picture. They're no longer independent entrepreneurs building a practice, they're working for a corporation, and functionally they end up working for the insurance companies and for Wall Street. And so that's what you're encountering. And there's no codes for counseling patients on improved nutrition, because this is all driven by, I'm going to use some strong words, the medical guild, that has become very invested in hierarchies. Those, the surgeons kind of sit at the top, and the internists, the specialists. That's why we end up with so much specialized medicine, where you have to go see this doc and then that doc and then the other doc, et cetera, et cetera. And it's increasingly rare to go to a generalist, except maybe at the very beginning, is because of how this coding structure is set up. It makes it so that if you're the generalist, if you're the primary care physician, you're basically put down in the medical hierarchy to the level of almost being an intake clerk, where the patient comes, encounters you, and then you say, okay, I'm going to pass you off to this or that or the other specialist, or I'm going to give you this pill, or I'm going to do some little procedure. Yay, then I can charge a lot more.
I've been wondering about this, or I've been experiencing this, and it's something to do with my husband. I said, well, we need to make an appointment to go see your GP so that he can refer us to like a real doctor that's going to solve a problem. I'm being sarcastic there, but it's like an intake clerk.
Yeah.
That was a brilliant way to say that.
And then each of those specialties have their own sub-guilds. And so you have the otolaryngologists there, you have the general surgeons, you have the cardiothoracic surgeons, you have the neurosurgeons, it goes on and on and on, all these little subcategories.
But there's never, back to this prevention, because I was asking about diet, because as I turned to YouTube, and I know that sounds silly, but we're talking about very highly, this will be, you're on YouTube, highly qualified doctors and scientists and researchers and health practitioners and nutritionists, et cetera, are on YouTube. And that's where I was getting all of my information that at least opened my eyes. I did not truly understand the issues of carbohydrates. Like I'm no expert.
Yeah, there's no financial incentive for a physician, even a primary care doc, to invest the time that you did in learning these subjects and then sharing that knowledge with their patients, even though that would potentially reduce the burden of cost, time, disease for that patient and for the country as a whole.
Well, Hippocratic oath, wouldn't it also just make us all healthier? And that's what a doctor's heart and passion is supposed to be about.
It's so yesterday. It was never a real rule. It's a set of principles. And now modern medical schools are often changing that, making it more woke. And what you're encountering now, particularly with the ones that are coming out over the last decade, the trainees that are coming from American medical schools, as opposed to those that are trained offshore and then allowed to come in to fill needs. The American medical schools are teaching the physician trainees to be protocol driven. So it's not just what is your diagnostic CPT code that I can bin you into, but then what protocol corresponds to that CPT code. So they're actually being tested on retention and knowledge of pre-developed protocols much like we all encountered during COVID, and so many people were so confused by that. Why is it that everybody is just getting remdesivir and ventilators, and if they come in and their oxygen levels aren't low enough, their blood oxygen levels, they're told to go home and sit around until their lips turn blue and then come back to the hospital. And no counseling or treatment or anything is provided. That was the protocol. And that's a whole nother story, but it's an example
of predetermined diagnosis and remediation, or it's a predetermined response by the doctor.
That is fundamental to the MAGA shift, is that this system is broken. It's insanely expensive. We are having reduced longevity, increased infant mortality, much more disease, and our costs are the highest in the Western world. So we're paying more for far less than these socialized medical systems that we all make fun of, but they're actually performing a lot better. They may not be performing great, and they may have long waiting times, etc. But who doesn't have long waiting times these days unless you're very wealthy?
When I saw this AHA and saw that it was focusing on prevention and other items, my questions were, how was this part of the plan? That wasn't a question that was in doubt, as if you began talking about these naysayers and that don't think Trump and Kennedy are moving fast enough. I think for myself, I'm just thinking there's things going on behind the scenes, and they don't sit there and have every conversation and meeting in the public sphere, and that there are things happening. And obviously this is evidence, this report that you dug up and wrote about on your Substack is evidence of what's going on behind the scenes that hasn't been made ready, or is not time for prime time, right? It's not for prime time yet, which you're actually voting in.
They got made a decision to socialize.
Exactly.
And so, yeah, there's a lot
but my question is this. You are identifying things that I think are on our minds. This whole sort of the I don't know if it started in the 80s or the 70s, where it started moving toward, say, big medicine, or a change from, you go to your family doctor and you had a relationship, and he was independent building a practice. And now I've seen everybody, like you said, is like an employee, doctors or indentured servants, better yet, of major corporations, and essentially, which is narrowing your options, because we're getting this regimentation, this coding system that they're making a fortune on. You've got predetermined outcomes, or diagnoses is the word I was looking for earlier. And I mean, we're talking about this a Leviathan that I can't even imagine how that is going to be torn apart. And I'm ready. You know what? Give me a hammer. I'll come and join you in DC, and I will do whatever you ask of me to take this down if you need volunteers. But
Elizabeth, there's a saying that applies here. And you hopefully have heard it before. How do you eat an elephant?
One bite at a time.
One bite at a time. Okay. And that
barbecue
one this is going to take a long time. This is going to take some major revolutions in how people think about things. It is not a simple task.
No.
And it's not going to be cheap, and it's not going to be right away.
There's going to be a lot of pearl clutching. There's going to be a lot of exposés and CNN and MSNBC, or whatever they call it now. They're all going to be hysterical. And then I'm hoping that MAGA and Mahala do not get impeded to speak. Well, the sky's falling. Chicken Little.
Thousands and thousands of child deaths because
Millions. Come on. It's millions. I want to know from you, what is it that is going to change, or is part of this AHA going to address studies? I remember when, I don't know if it was USAID was being exposed, and we saw that there was multiple studies in Ethiopia on taxi cab drivers and the use of masks. And I don't know, you probably don't remember that. There were so many thousands of things came out. And I thought, we're spending money, and I didn't even know if it was a lot of money. I wouldn't spend 42 cents on Ethiopian taxi drivers and masks, and I don't even know what their goal was in this study. And I think a lot of Americans are praying that studies are now rigorous, but not only rigorous, that they're publicly required to be presented to the public in an easily accessible way, so that those studies that are always hidden, that give us the true answers, that they're always required to be put in front of the people, that all these studies that are being funded are actually, that we know what's being funded, because what we want is studies that are efficacious, they're relevant, they really mean something to the health of the American people.
Well,
is the AHA going to be, and HHS, are they going to be addressing studies and where the money goes and how it's spent?
so most of that kind of stuff you were talking about is research grade, and most of that money flows through J. Bhattacharya and NIH. So NIH is pretty much protected from this AHA reorganization. The CDC certainly does many studies having to do with a variety of topics having to do, for instance, with environmental health. And as I recall, I mean, there's so many things here, I don't recall all the nuances of the AHA plan, but environmental health was part of the CDC, as I recall, is being pulled out of the CDC and put into AHA. But CDC is remaining responsible for infectious disease and epidemiology and kind of the whole vaccine shtick. So they're going to get refocused, and their CDC is going to have a lot less of the other thing that you're touching on with the Ethiopian mask example.
Taxi drivers.
Well, it's international health. And international health now is, historically, it's been more of a CDC task area. And that's being pulled out and is being placed, I think, partially in AHA, but also in the State Department. So in that also those plans at the State Department and the interface between the State Department and HHS are in flux. You can read about this in part in my speech to the European Parliament. That was another Substack a couple ago, in which I quote from the State Department the new policies that the United States is basically going to bypass WHO, UN, WEF, those globalist organizations in their public health investments, and focus on bilateral negotiations having to do with international health. And then instead of this kind of imperialistic, frankly, ugly American stance of we are telling you what you should be doing, and you need to comply with what we're saying if you want to get our money, that's no longer going to be the focus. It's going to be bilateral, and the focus is going to be on enabling local solutions and empowering local governments so they can start to solve their own problems and carry their own weight, and pulling back so that the U.S. is more focused just on the issue of how to prevent novel infectious disease or other threats from entering the domestic space, so the homeland. So protect
So
homeowner.
foreign nations how to fish rather than give them a pole, teach them how to fish, and don't hand them a dinner every night.
But
And
for
tell them to
Christ's
eat.
sake, pick metaphor. So that's another major sea change. And when I spoke about this using not my own language, but rather quoting the State Department, because I don't want to get in trouble, because technically I am a employee of the federal government, although I'm paid. I have to watch myself in making sure that I don't speak on behalf of the government, but I can quote the government. So when I was quoting in the European Parliament these State Department policies, there was really strong, enthusiastic support for that position, as opposed to the more traditional, kind of heavy-handed, imperialistic American position.
And are we not looking at their? We're Americans. We're thinking we're the greatest country on earth, and blah blah blah. Yes, I'm MAGA all the way. I want us to be, but at the same time, when you get administrations and bureaucracies that are pushing things that, like the COVID jab, right? When to use that as an example, if we're going to other countries and we're funding, say, inoculations or vaccines, and then we're putting sterilization, I don't know, whatever chemicals that cause sterilization.
And just to provide a little context, you're referring to some very clear, this is not a conspiracy theory. This has to do with a Gates-funded program that had some U.S. support, as I recall, in Africa and also in India, in which there was a surreptitious effort to sterilize women. It was done in the context of vaccine deployment. That's not crazy talk. That's not conspiracy theory. That actually happened. And it illustrates the kind of nefarious aspect of many of these historic policies and the strange bedfellows that are behind them, that are advancing other agendas. Just the polio surveillance was the cover story for the blood draws and pediatric blood draws and testing in Afghanistan that allowed them to identify a blood relative of Osama bin Laden and track down where his compound was. They used public health and this kind of testing as a way.
It's a danger in the concentration of power, and even if it's American power, when it comes to the medical practice or industry or the institutions, it seems to me that there's always danger when, from the top down, we are requiring foreign nations to conform to whatever we determine to be the best practices that might be in their country. But but shouldn't we
remember that we have this kind of dark shadow of this huge industry that we call pharma?
Mm-hmm.
It is like the finance industry, so powerful that they call the shots for many Congress people. I'll just put that way. They have undue influence over the policies of the United States government, including foreign policy, and they from time to time exert that influence to advance their commercial interests at the expense of common people
and health.
Yeah.
Well, bringing it back to the United States, we should be focusing on the United States. We do want to prevent the spread of infectious diseases from other countries into the United States. Absolutely. We don't want anybody to die around the world at all from bad medical practice and infectious disease, et cetera.
Of course, we're generous people, but that doesn't mean it's our job to be the medical policeman for the world.
And we don't want anybody else like WHO to be our a medical police in America. So in America, if we're going toward prevention, which is such music to my ears, I'm wondering, and I asked about these studies, and without going back into that too deeply, is there going to be a push? Oh, well, you said that this really is not part of AHA as much as Bhattacharya's area of the National Institute of Health. But just as a side note, do you sense or have you heard that there's going to be a rigor to the requirements of what we're spending money on and who we're giving it to do the studies and what the purpose of those studies are? Because so many of them seem random and almost like vanity studies, or I just need some money, so I'll make something up, and because I need a grant from the federal government. I want that money to be spent. Like, I would love a study spent on gut health. Let me give you my reasoning on this. I'm hearing, and I've been hearing for years since my husband had his strokes, about gut health. But then when I go to research it,
Sabine and Hazen have common cause on that one.
Oh, really? Okay. Well, see, the thing is, I know that I don't care about the Nigerian taxi drivers, mask use. I do know that if the federal government did some sort of study where it brought together all of the studies and did, what do you call those studies where you do the meta-analysis of some sort, and said, okay, American people, this is what this whole gut health thing has been about. Because when I go to, I'm thinking, I want to make sure that I have good gut health in my family. The first step I take, and I start saying, wait a minute, I have no idea if this is a charlatan. I don't know if this is money I'm throwing out. I don't know if this is counterproductive or it actually works. And I'm thinking, that's what I wouldn't mind some money spent by the federal government where I could go someplace online and see these are the studies, these are the best practices, this is what we have to offer you as far as answers. Why shouldn't I be able to get something like that when we're spending billions?
Well, you should. And what you're talking about is considered to be fringy. It's outside. It's not cool. The honest truth is that science and medicine are subject to fads and trends, just like any other human.
Mm-hmm.
And the cool kids right now, and that get money, often are focused on various forms or applications of molecular biology or genetics, and are in the latest sequencing technology, etc., and big data. And those, if you want to get funded, those are kind of shortcuts to increasing the probability of winning a proposal. People don't appreciate how wickedly competitive it is to get grant funding out of the NIH. They also don't appreciate that if Jay, I think he's now learned the lesson. I tried to mention it to him early. He thought that you could just kind of put in motion, and within a few months you'd have grant proposals and awarded grants to do whatever the thing is that you're interested in. It historically, it takes 5 years from the point where somebody at NIH says, listens to you. You might come in and you have a friend at NIH and you say, damn it, why don't we have this? And they say, you're right, Elizabeth, we need to have that. I'm going to do something about that. We're going to put that in motion and we're going to get those grants awarded. Typically from concept to issuance of awards is 5 years.
Does that make sense to you?
Everything has gotten incredibly bureaucratic and cumbersome, all in the interests of equity and inclusion and all of that.
Oh, I'm so against equity and inclusion.
What we're up against is a really sludgy environment for deciding what gets awarded. And part of the problem in that comes under the guise of this old friend that is causing us so much trouble: peer review. And so what does peer review mean in the context of grant and contract proposals? What it means is that your competitors or allies get to criticize a proposal that you've developed and submitted to the government in response to some opportunity or solicitation. If Jay was to say, we want studies involving health or say autism,
Right.
and then they say, well, we want studies that look at big data samples for analyzing gut microbiome flora and its association with autism or whatever. So then all those applications come in, and on a good day, about 1 in 10 get funded. So the other 9 have just wasted 6 months of effort building their kits. And who passes through the gauntlet of peer review are often the people that are putting out things that support whatever the dominant paradigm.
Yeah.
Because that's the lowest risk.
Can we change that paradigm, the dominant paradigm?
So the good news, Elizabeth, is that what you're talking about are exactly the kinds of things that Jay Bhattacharya is saying that he's trying to do. But it's a labor of Sisyphus, the old Greek myth, pushing the boulder up the hill, and then every day it rolls back down on top of you. So that's a pretty good metaphor for trying to get anything done in the federal government. This is one of the amazing things, just to say it about President Trump. And I know probably like many, you're not a big fan of Operation Warp Speed because of the work product.
But he got something done.
He got the government to put something together. And he broke down the boundaries, and he broke the silos, and he got people to get the job done. I disagree with how they did the job.
Right.
Disagree with work product.
Agreed.
But I admire the ability of the president to motivate the bureaucracy to get stuff done. And he's in the middle of that. That's the thing about the MAGA Commission, is that it is another all-of-government response, much like the Operation Warp Speed, in which the president is knocking heads and saying, get the job done. So will Jay make significant progress? Let's imagine, or just as a thought experiment, that Jay he manages to jam this proposal for evaluation of relationship between gut microbiome and gut health and cancer. And he manages to get that through the system and awarded. Those contracts and grants will typically be 5-year terms. So we're not even going to know the outcome of that until after President Trump is back golfing in his various golf courses in Scotland and Miami. And that's the way things are right now. There's the hope that artificial intelligence and big data systems and getting access to large amounts of medical data and cut through that process. That's aspirational. And the problem with all that is often that in order to do that, you have to sacrifice confidentiality, which here in the United States, we don't do. We've got laws against that, including HIPAA. In Europe, under their socialized medical care systems, and this was something that I said in my talk in Europe, I lauded that they have better databases and better ability to ask these questions. And of the 47 minutes in my talk, that's the one thing that Politico pulled out, was that I was complimenting the Euro-socialist medical systems. But that's part of why we have these tech giants wanting to whether it's Apple or Palantir or whatever, wanting to get access to our medical data is because they think that is going to enable breakthroughs. But is the other thing in this whole equation, Elizabeth, is that this idea of personalized medicine or kind of big data medicine or genomics-based medicine was really first floated in President Obama's first State of the Union address. So it goes back a ways. We now have a number of years of experience in trying to advance those ideas of application of genomics and big data on individual and public health. And it turns out that the vast majority of health is not driven by your genes or even your epigenetics. It's driven by social context factor, where you live, the amount of stress you're subjected to, your socioeconomic status, how you were brought up, all those things. Something like 70 to 80% of the contributing factors to your health. And so if we're really going to make America healthy again, what we have to do is address these big issues of, do you have good eating practices? Do you have access to clean food? Are you in a healthy environment in terms of your home and living conditions? Are you subjected to excess stress that will compromise both your mental and physical health? Stress like comes with fear of your job security. So it's those things that are the big drivers of health.
So it's not genetics. All this, did your uncle have cancer? Did your mother and sister had her breast cancer?
But more important than that, like we know from the tobacco situation, it has a lot more to do with lifestyle and practices and food and all those kinds of things. So that gets back to your point. This reinforces the starting point of this conversation, which is nutrition is the gateway to health. And we have to somehow break out of this metaphor where medicine involving giving you a pill or a procedure is the pathway to health, and that a medical practitioner, as if there's some kind of voodoo doll or practitioner shaking a gourd over you.
Which doctor
is going to be the one responsible for your health? No, the one that's responsible for your health is you.
And so access to information that's true and the dissemination of it, and I would say early childhood education, so that throughout can you imagine if they started teaching systematically the health risks and healthy living and lifestyle in children very, very young, and consistently did that through graduation?
I've kind of got a little bit spooked about state-based education.
Oh yeah, I think it should be abolished, but I mean,
so here's my pushback. Could you imagine if parents took it upon themselves to teach their children good practices, healthy health promotion practices, that parents were given the tools to become good educators of their children?
Absolutely.
So that rather than having the teachers union decide whether you should eat an apple or an orange and how many, we have parents empowered with information, and they can employ that information in culturally appropriate ways consistent with their own religious and social beliefs to raise healthy children. I think that's where we need to get.
I think that what you're saying is absolutely true. It should be parent-based. I really wasn't advocating for government schools because I think they should technically be abolished entirely. So I agree with you. It's about parents, but I think access to information. If you look at what most parents, I don't know if it's most parents, but many, many, many parents send their kids with the lunchbox, and there's a juice box in it, which I think is basically, a death sentence. Okay, you've got a white bread sandwich, you've got a dessert, you've got chips, you've got a fruit box. I mean, a fruit juice in a box, and because it has an apple on the front, you think it's healthy, and so and yogurt full of sugar, and this is supposed to be a balanced diet. I don't think those parents know that fruit box diet is deadly to kids, and this is why so many young children are have type 2 diabetes now, or that 70% of American kids could not be taken into or admitted into the military because they're obese and unhealthy and out of shape. And so transparency, I'm hoping that AHA does that. And I'm also hoping that there might be some coordination with over processed foods and the FDA, and I don't know who deals with food manufacturers, but I found out, to my surprise, that
So the answer is FDA and USDA kind of have split responsibility.
right. And I was saying the Department of Agriculture, and I don't know how much that plays in, but is there going to be a coordination so that we can start knowing about what's in our food? Because I don't believe we truly have any idea. I think there should be a national database of every food additive that is in every single brand of all foods in any grocery store in the United States of America. And we should actually know what those things are, not in gobbledygook for scientists, researchers, and doctors, but I mean in plain language. If you go and you buy tomato spaghetti sauce in a jar, what's in there and how fast is it going to kill you? Well, I've been sarcastic.
So what we're illustrating is the complexities of what Secretary Kennedy and his team are up against. Is how do you turn? This is like turning an aircraft carrier in a narrow harbor.
Yeah.
It's just a tough job, and they're doing their best. But it's again back to the elephant metaphor. They got to eat that elephant one bite at a time.
That's right.
And what we need, and that's what I'm arguing in these two essays, the yesterday's and the one today, is we really, now's the time we need to get Congress activated.
Do you know anyone who's ready to sponsor this bill for the AHA?
I was just talking to one of the senior people in HHS responsible for policy, and they haven't even thought that through. I said, Thomas Massey, well, problem with Thomas Massey is he's not in the leadership right now. And so you need, in order to do this, you're going to have somebody within the leadership to be the primary sponsor. And, the leadership right now can't get the federal budget.
Oh, yeah, that's a good point. So we're kind of in a holding pattern right now because of the so-called government shutdown.
But
and all
what we can do, and that's what I'm trying to do, is give your listeners and yourself and anybody else that wants to pay attention the information about what needs doing. What are the legislative priorities for MAHA?
Okay, so give us, in closing, what do you want us to do? What do you want Americans to do?
Well, for one, work together to educate each other and change our habits. That's the decentralized thing. Is the truth of it is health begins at home. Health promotion begins with you as an individual. As my friend Ryan Cole likes to say again and again when he's giving a lecture, the best physician you'll ever have is in this room, and it's not me. It's all of you. And you are your best physician. So take the time like Elizabeth did and invest in understanding nutrition, understanding the determinants of health and